Good afternoon, everybody. Thank you very much for joining us today on our latest webinar here at HealthMonics. And today we'll be discussing Conquering MIPS 2021, taking a deeper look into gaps in care analysis. So today it's going to be myself, Michael Lewis, MIPS specialist, as well as we have Lauren Patrick, our president and CEO, that's going to be jumping in throughout the presentation. Couple of things for you to understand. Those who have been part of these presentations in the past know exactly where our handouts are and where to ask questions. If you don't, they are on the right-hand side of your screen. You could ask the questions, and if we have time at the end, I will either be asking the questions then, or you can definitely, will get a response from us at the end of the presentation sometime later today or tomorrow with your questions, or with our answers, sorry. And then on the handout side, you'll see not only our slide deck, but a little bit more information about our programs here and what we have to offer you. So today we're going to review a couple of things. We have 2021 MIPS review, just to kind of get us kickstarted and everybody in the mindset of where MIPS is currently today. Then we're going to go over how to attack the gaps in care. And then we'll also take a look at the benefits of analytics and how analytics can really help you with MIPS reporting. So as a review for the MIPS section, what we have here is the split up of MIPS. We have the cost, quality, improvement activities, and promoting interoperability, and that's how the split is for 2021. That changes next year as cost moves up to 30% and quality drops down to 30%. Based upon your specialty and what type of patients you see, you may be exempt from certain categories here. And in this year, if you're exempt from any of the promoting interoperability, improvement activities, or cost, all of that will be re-rated towards quality. On the right-hand side, you can see what the adjustments are for this year. 85 points will get you into the exceptional performance bonus. Above 60 will avoid the penalty for you. And then anything from 15 to 60 points will be a scaled negative number. So if you score 15 points, you'll be right around that -9. Anything below that will be -9. And then between 15 and 59.99 will go from -9 all the way up to 0. All right. So as I said, the minimum threshold to avoid is 60%, 60 points. Also, what you need to know here as well is that next year they're planning to move that anywhere between 74 and 75 points for 2022, and also moving that threshold up for to get into the exceptional bonus range. And predictions for next year actually are pretty interesting from what we read in the proposed rule, that there could be up to a 14% incentive in 2022 performance year paying out in 2024. So here you can take a look at what the total adjustment is based upon your score, kind of what I went over on the previous screens. Here you have at 60, it's at the 0 mark, and then all the way up to above 7% for 2021, and as little as 9%. And for those that aren't performing, the number at top, the 7.36, is adjustable based upon what the average score is throughout the year, because this is a budget neutral program that the people that fall below and are penalized pay the winners up at the top. So 2021 introduces the first year that there's no real easy way out. With cost increasing to 20% and 30% next year, your direct control of your score is really reduced because you have the impact of outside influences for those two categories, or for the cost category, as you would compared to having a direct influence on IA, PI, and the quality. If you score perfectly in every other category in 2022 and get a 0 in cost, then you still be below the anticipated penalty threshold for the year. So you have to really do well on all categories and pay attention to cost as well. Couple of the reporting scenarios that I mentioned earlier, how you could be exempt from certain categories, you could see on the bottom right-hand side of the screen. These are two of the most typical category splits that you may have. It's really important for you to know what you are eligible for. There is a small practice exemption for promoting interoperability, that if you're not on an EHR or you don't have the information that you need for PI, you need to go to CMS and take that exemption. And that's going to put everything into the quality section. So how do you get to 60 points? So with 60 points, I'm going to take showing that everybody gets the improvement activity points at 15 points. And then you can take a look at each one of the different categories and where you fit in, whether you don't have exemptions, if you're not in part of cost or PI, or you don't have both, and see how many points you need to score. The key goal here is to get at least 50% in each category that you're eligible for, and 100% in IA, and that will get you to where you need to be for this year. So if you're not doing very well and you need to pick it up, you need to get to 50 points. Fortunately for PI and IA, you can wait until the end of the year. You can do the last 90 days of the year and make sure and kind of know what you need points-wise from your PI to do well. So we're going to take a look at gaps in care, and I'm going to throw it over to Lauren to get this part started, and then I'll be back with you in a little bit.
Thanks, Mike. So yeah, as Mike's talking about, I think that what we're seeing is MIPS is becoming more and more difficult. We're really transitioning from what CMS is calling the transition period, which is up through 2021 and 2022, and now CMS is like is really saying, okay, we're going to get serious about this now. It's got to be as many people are penalized as are getting the incentive, and we want the incentives to be real. I know that a lot of us have seen over the last few years that even if you scored really well, there just wasn't a big incentive. And I think what we're seeing is perhaps in 21, but certainly for 22, there are some big incentives to be gleaned. However, having said that, the downside is it's going to be a lot harder to get those incentives. So what we want to do is we want to start talking a little bit about gaps in care. So I'm going to step back, and this will circle back to, we'll get back to MIPS in a moment, but just to take a step back and talk about gaps in care, because that really does affect both your quality score and your cost score. And so if we can address gaps in care on a more holistic level, then we're going to see benefits in our MIPS program, and we're going to see other benefits as well, which I'll talk about in a moment. So what is a gap in care? When we think about gaps in care, they really refer to the difference between the care provided to the patients and what our best practices, what our evidence-based practices say we should be doing. And these can happen for a lot of different reasons. Either we don't have proper workflows in place, our providers don't know the current standards of care. I know we've worked at HealthMonix a lot in continuing medical education to help let providers know what the current evidence-based practices are. But we still have a lot of gaps in care, both in terms of knowledge base and because of other reasons. So what are the different categories into which gaps fall? So the first is your routine screenings, patients that just aren't complying with recommended screenings based on age, based on gender, based on their history, based on diagnosis. So we see patients that aren't getting appropriate cancer screenings. We see patients that aren't getting appropriate labs, depression screenings, fall screenings, cardiac screenings, and a lot of these align really closely to some of the MIPS measures. Sometimes we see a lack of follow-up by the provider, lack of follow-up by the patient, and routine screenings just aren't happening. Another area where we see a lot of gaps in care are communication and workflow. a patient's new diagnosis isn't shared back to their PCP, or a referral isn't communicated appropriately to the referred physician or back to the referring physician. And so we see gaps in care there. Of course, we see patient adherence gaps, which are some of the most difficult in many cases to conquer. We see evidence-based practices that aren't being adhered to, like I said, things like even just basics like monitoring A1Cs, making sure that the appropriate care is being put in place for condition, that we're not overusing different diagnostic labs and or treatments that we shouldn't be utilizing. And then plain old routine care, patients not getting flu shots, patients not getting a lot of the care that they would need. And these are all gaps in care, and they affect not only MIPS, but a lot of other arenas. Next slide, please. So gaps in care can really show up a couple different ways. They can be actual misses in the care. They can be that the patient isn't getting their labs done, or the communication isn't happening, or they can just be, I say just, they can just be areas where you're missing documentation. So I know back in the day when we at Health Monix were doing a lot of maintenance of certification programs with doctors, the doctors would say to us, oh, but I'm doing everything that I'm supposed to be doing as the standard of care. But then we'd look in the records and it just wasn't getting documented appropriately in the record. So half of a gap in care is making sure that you have the appropriate documentation and that documentation is being shared. So even if you're giving that patient the standard of care, we need to make sure that it's getting documented in a way that is shareable, both internally to your organization and to the wider network of providers that are working with any given patient. So for most organizations, a lot of times what you'll see is you'll get a report. You'll get a report that says, we used to call this the you stink report. On Monday morning, you would get a report. It would tell you all the things you didn't do, and it wouldn't really give you the opportunity to correct those. So what we really want to do is not just tell providers about their past performance, but we want to give them a way to get into the data, to review the data, and to fix the gaps in care. So that's what we at Health Monix are working on. We don't want to just take your data at the end of the year, consolidate it, and send it to CMS. Our goal, our mission is really to help providers see their data soon enough that they can find the gaps in care and then resolve those. So we work as closely as we can with the providers that are engaged in our programs to help them close those gaps in care. So why are they important? As we can see here, there's a lot of impact for these gaps in care. Some folks have documented in a study that there's over $400,000 over the lifetime care of a patient if the appropriate care is not given early on. I was at a conference a few years ago, and there was a doctor that was actually talking about if we gave patients in their 20s that are diagnosed with diabetes, if we gave them a large financial incentive of 6 figures, and we said, as long as you can keep your diabetes in check and follow the standard of care, we're going to give you this incentive, they would actually cost less for that patient than all the care you're going to have to give that patient throughout their lifetime if they don't adhere to appropriate standards of care. So there's the overall cost of care for patients. There's the future care that's going to have to be given. There's the cost of all that future care, certainly cost to your organization. I think there's a frustration when we see patients that aren't getting appropriate care and their conditions are not improving or at least being managed. And then of course, there's all of these value-based care programs that we're now seeing come to fruition. And there's ratings that come out from these programs, there's reimbursement impacts, there's incentives that can be gained. So it's important to it's becoming even more important to look at these gaps in care and become proactive. And again, that's what we want to work with organizations to help close those gaps and encourage providers to be more proactive. There was also, I think, I just saw a study, I think in Health Affairs, that talked about, a lot of these gaps in care result in ratings, and the ratings result in star ratings that are published, and patients will pay, I think I saw an average of $2,000 additional to go to an orthopedic surgeon that has one more star than another one, as long as that provider is within their geographic area. So there are benefits in terms of engaging patients as well. Of course, we see that some gaps in care are based on patient compliance. For those, it's certainly more of a challenge because it's not always within your control. It's a higher lift, it's a harder pull to get those patients to comply. But we can see there's so many areas here that we can work with patients and really work to improve their care, close the gaps, and help them have a healthier life. Again, we see this multiplied based on what's happened over the last year or so. The pandemic has certainly had an impact. Patients are being more challenged to meet their care guidelines. I know I, for one, didn't go in for my mammogram for a year. So, it's important that we look more closely at these gaps, and perhaps assuming that we're not overcome by the Delta variant, that we try to get our patients back in compliance as much as possible. That's my soapbox. When we look at how to close a gap in care, it's really a continuous improvement process. It's not a one-time deal. So again, what we look to do is we bring the patient data in. At least on our platform, what we do is we'll bring it in from multiple sources, wherever we can get that patient data. We are improving our system so that we can bring in a lot of different data. Of course, we've been able to bring in billing data and EHR data. We're looking at bringing in other factors such as social determinants, geographic information, a lot of additional information, and provide analytics and feedback back to our providers. So we bring all that data into our analytics, and we display the gaps, and we work with providers to see the gaps and determine what the sources of those are. So again, very much a PDSA cycle, continuous improvement. I know a lot of people look at this in different ways. You can use a Six Sigma approach, but look at the source of the gaps. Where are those gaps coming from? Perhaps it's a workflow issue. Perhaps it's a coding or a documentation issue. Perhaps you have physicians that are putting data in one field that isn't getting captured and communicated to other providers. There's a lot of different reasons that gap can be coming forth. Sometimes it's a matter of better communication, both internal to your office, external to others in the network, external to others in the geography. Sometimes you need to use that gap data to reach out to patients. And again, what we're doing is putting in place different methods to address these gaps and then circle back. So it is a continuous improvement loop. As providers work to close these gaps, we provide continuous feedback, and then you can continue to look for pockets where there's still some areas for improvement, and this just continues. So I think that's the end of this section, Mike. I think now you're going to talk about some actual data reports and how this can be put into place in a very tactical level.
Great, thanks very much, Lauren. So we're going to go over into some of our actual insights here. So the next couple of screens that I'll share with you are really taking a deeper dive into what you can do with such data that can become available to you. So what we have here is, and a lot of these screens are directly from our system, but some other programs may offer you the same opportunities. But what you have here is to discover where your gaps are. So you could focus on one quality action like you see here, where we're taking a look at measure number 110, which is for your flu immunization, and then the status of not met, and be able to really take a look at what it looks like for your entire program, practice, or an individual provider, and break it down by patient that are missing the measure with the flu vaccine. In our program, you're able to export that list out and then take it back to the administrators of your practice and decide how and why you're missing that data. Because there could be many reasons, which we'll get into in a little bit, of how you're missing and how you're missing certain data in your system. Another way to look at your data is actually focusing on an individual patient and seeing where they're missing data. So you can see here down the bottom, you see this patient, George here, who actually has missing data for 4 different measures or 3 different measures in the system, including the advanced care plan and colorectal screening and pneumococcal vaccine. What's nice about a lot of these measures and why it might be worth tracking them is that all of these measures are once per performance period. So you could actually go back to this patient, bring them in for a visit or whatever it may be, and update this information, because what our system will do and what it should do is override that information in the advanced care plan to say that this is going to give you credit moving forward. Another way to even break down the data further is, we were looking on the patient level before. This is taking a look at the visit level. Where are you missing data on individual visits? Maybe you want to look at a time frame or an individual provider or an individual patient information, and you're able to take a look here and you'll see the patient ID, the data service, as well as all of the measures that they're not met, or even have the ineligible list. It really is important to track these in the beginning of the year, especially as we go into something like 2022, where scoring very well, as I stated earlier, will be of the utmost importance. So for the standpoint of taking a look at it right from the beginning of the year, you can make the changes right away instead of waiting until the end to make the changes. You can see where your gaps are, see what information that you need to go back and get the correct information for. You know, there are a lot of ways, and I'll get into in a minute, that this information can be missed. So learning about what data is missing. So if I clicked on one of the individual measures, and now I'm taking a look at the preventative screening for depression, measure number 134, what you can see from this screen is what it looks like within our engine. Understanding what is actually missing is important. So right here, you can see we have the matched code for 99202. So the patient is eligible, and they also do not have a diagnosis of bipolar disorder or depression, which would make this patient eligible for this visit. Now I'm going to zoom in here onto the 4th selection and see all of your options for scoring. What we can see here is that we could not find a code in the system, so this is missing. Why is it missing? There could be many reasons why it's missing. It wasn't brought over through the data. The doctor didn't document it correctly. They handwrote it in on a paper note, or many different reasons of why it was missed, or it was in another visit, which in measures like this, we can take a look back in our system and give you credit for some of these measures that are here. So what you see here are all the different options you can have for the depression screening, as well as your met, not met, and excluded for each one of these.
And
So what are
again, I
some, oh,
want to point out, Mike, sorry for jumping
mhm.
in, but it's not just about MIPS, but it's also about, if the patient's, I don't know how many of you have gone into your doctor and the doctor's like, okay, I'm going to do a depression screening. And it's like, well, I just did this last week at my other provider. So it's really great if you can coordinate that data and understand that, a practice has already been done and it doesn't have to be done again. So there's really benefit to the patient as well.
You got it. Thank you, Lauren. And please, always feel free to interrupt me. So, why is the data missing? There are common traits for their gaps in care. So, my experience working in individual practices in the consulting realm prior to doing this really opened my eyes to all the different ways that you can miss the data. So, for instance, patient workflow during a visit isn't standardized. So, there isn't a standard way, and each medical assistant or nurse or doctor does things differently. Well, if that's the case, then you're never going to get it down pat. So really being able to take that and make one standardized way that you're getting your information per measure is important, because there are measures that can be done at the front desk by a receptionist, and then there's measures that need to be done by a doctor in the back room. So understanding that and standardizing that's very important. Documentation in the wrong area of the EMR. This becomes very important, and we'll dig into it in a minute here, but there's many different places in EMRs that you could put data, whether it's structured or unstructured. There's a lot of different options where you can put the same information, especially when you take a look at things like lab results and so forth. Not accurately coding patient visits. This can be anything from not putting enough of their ICD-10 codes for the different diagnoses they have, or it could be not accurately putting a CPT code in the system. If you do that within the program, your patients could end up as not being eligible for something that you worked hard to make sure that you did. Misinterpretation of measure specifications. A couple screens on this, but this really happens a lot when there's measure changes. And when are there measure changes? Well, CMS changes the measures every single year, and they'll add exemptions in, they'll take exemptions out, they'll add certain areas into the measures that really are, it really can change how you are going to be working with each one of the measures. So paying particular attention to that. Quality action was completed by another provider and not shared. So this is what Lauren was talking about a minute ago. If you have multiple providers within your practice and one provider did a depression screening a couple weeks prior to you seeing that patient, you should be able to get credit for that measure. So being able to pull that data in through your EHR into your patients is very important. So patient workflow. I used to come up with these with the offices I work with. This is a very, very scalable project, but if you were to give a new patient intake form and even have a separate form for existing patients, that would include them having the ability to put the name, date of birth, date of service, and the provider they're seeing, as well as answering all of the questions that you want to track up front. So some programs, you don't need this as a separate form, and they actually have I've been to some doctor's office where they hand you an iPad and you're able to put these answers in for some questions like that. It's a typical intake form, and having the ability to really get some of the base MIPS measures out of the way. It doesn't take much to ask a patient if they had the flu or the pneumonia vaccine, or whether they are smokers or non-smokers. You're asking those questions already, so why don't you get it documented in an area where you know you can answer it for your MIPS reasons. I've seen scores for MIPS program drastically increase just by instituting an intake form at the front desk. So this is a scenario as well as when I talk about standardizing EMR documentation. So trying to meet measure number 1 for diabetes, hemoglobin A1C poor control, there are 3 providers in your practice and each document on a patient's A1C in different locations. So Dr. A depends on A1C documentation from the lab results. So it's going to be delivered directly into your EHR from the lab of your choice, and that's how that doctor is going to make sure that it is documented in the system. Dr. B documents the A1C in the patient's chart under a lab results section. So maybe showing in a different area where the A1C for Dr. A goes to an actual source that says A1C, while Dr. B is just putting it in one common area that says lab results. And then Dr. C, documentation is part of a dictated note, so not as structured data. So what changes would you make to fix this nightmare? And this is a nightmare because getting this data could be a lot of manual effort throughout the year, or in a lot of cases, come the beginning of the next year, you're looking back and individually going through charts. So making sure that structured data is the most important part of all of this. Making sure that data comes in a structured manner, and make sure that you're taking it from the same location. So work with each one of your providers to come up with one area to put that information in, can make this much easier moving forward. So when it comes to proper documentation, I mentioned earlier could interfere with their measure eligibility. There are a couple of common scenarios that I've seen through my time working with providers. So that there's measures that need a diagnosis code for patients to be eligible. So you have measure number 236. You need to have a diagnosis of hypertension for you to have that. Well, if you did the work and if you checked their blood pressure and so forth, but you didn't put the diagnosis of hypertension, you would never get credit for that patient that you're doing work for. Other measures, like measure number 134, depression screening, you actually need the lack of a diagnosis for depression or bipolar order to count for that one. And then there are measures like a diagnosis that there's no diagnosis needed. Many of your common measures, your flu vaccine, your pneumonia vaccine, advanced care plan, and as well as your colorectal screening, breast screening, documentation of current medications. You don't need any type of diagnosis to be eligible for that measure. So misinterpreting measures is a big problem, and it's something that our support team often handles those questions on a daily basis. So understanding the measures can save you a lot of work. You don't want to be doing extra work for those patients that you don't need to actually do the work for. So for instance, common measure mistakes like 397 melanoma reporting. I've worked with dermatologists for the last 10 years, and this is an area and a question I get asked often. Can I do the melanoma reporting? Well, the only way that you can do the melanoma reporting is if you're actually doing the biopsy. So you need to have billed an 88305 for this patient for you to get this. So a regular dermatologist that isn't also reading their own slides would not have the opportunity to do the 397 melanoma reporting. That is for a pathologist only. Or measure number 110 is a very interesting one because it's a very popular one and one that has changed so much since the beginning of the program when it comes to when you have to ask it, how often, and so forth. But this measure must be submitted at least once per patient seen between January and March, and also seen once again between October and December of the flu season. So you need to have both of those, either from the reporting eligible clinician or from an alternate care provider. So they need to have asked these questions twice during the year. Very interesting how the flu vaccine works and how many people don't understand that that's how it works and sometimes are caught off guard at the end of the year when they go to report. Impactful strategies for an exceptional performance. So understand and attack your gaps in care. So determining what data is missing and seeing where it is stored. So for instance, if you want to verify information like your A1C results are documented in a structured format, we talked about that. Make sure not to miss out on measured performance opportunities by bringing data in from all available resources. So a lot of that information from most of the ones on the call today is going to be located within your EHR. But however, there is good information that could be found in any type of data file as well as billing file. Some people have information that is located in some type of annual wellness checking program that they have. There are some people that have information that is in an RCM that they work with, or even, if you're able to get information from some type of format that checks patients in at the beginning. So all that information can help you build not only your numerator information, your denominator information, but answer some of those MIPS questions that are important for you to do well in scoring. Confirm that your providers are documenting correct, and if not, work on them to get better. The best time to work on that is the beginning of the year or even the prior year. So use this year if you're still not doing it at this point. Use this year to get better so that in January you are kicking off with the ability really to do well next year when it's going to, I hate to say it, but really count for your score. And if you're reporting on measures that need to be only done once per performance period, know where those gaps are and know what patients are coming in, and documenting your EHR. When that patient comes back in, you have to ask them about the advanced care plan, put a special note in, star that patient to make sure that you're able to attack those gaps in care sufficiently. So now we're going to take a little bit look into the analytics and how analytics can help you. So as the MIPS program becomes more difficult, being able to dig down deep into that data will help play a pivotal role in future success. So analytics help identify locations and providers that are outliers. So a really important ability to really take a look at, do you have underperforming providers? Do you have ones that are doing well and that can help you with the others? Or take a look at how they are working as far as a workflow standpoint, and can you work with them to see if you can change those workflows in the other providers. We'll also be able to take a look at identifying patient populations that are being underserved. Is it those diabetic patients that Lauren was mentioning earlier that you're not getting the A1C scores that you need to do? Or is it your younger patients, those patients in that 18 to 21 range that you're not doing the smoking cessation counseling for, but you need to? Um, Analytics can also provide information on quality metrics to use better your agreements with private payers. This is something that's come up a lot lately. You're tracking this information on a large basis for all of your for all of your patients and all of your payers, even though the impact really is on just your Medicare patients. That's where the reimbursement comes in play. Well, why don't you use that information and go back to your Blue Cross and Blue Shield or your Aetna and talk to them about what you're doing in the MIPS category to work better deals and be able to really use that information. And if you provide a company like ours the ability to, if you provide us with your insurance information, we could give you specific reports back that you could take to them that allows to show them how you're doing with their patient populations. And the analytics can also take a deeper dives into your gaps in care, tell you where the best areas are to go. So not only that will it show you an area of what you need to work on, but it really will dig deep into the areas that will give you the best opportunity to score well. So what you see here on this first one is a performance report drill down by location. If you have multiple locations within your TIN, or if you have multiple TINs, um, that's what you're able to see here. You have the opportunity to look at each one of these practices and see where they're scoring and decide where do you want to place your impact, and where do you want to make the change. Is it worthwhile to, for instance, to talk to this provider group that only sees 2 patients but is doing poorly? Probably not. But does it make sense to work with a group that sees almost more than 50% of your patient population and is only doing okay? That makes sense to work on this by a practice standpoint, really understand what it is. Do you want to take a look at it by provider? So you could break it down by provider and see which providers are performing well and which are performing better. So what you're seeing here are from the top to bottom for this measure, this inverse measure, which is measure number 1, meaning that the lower the score, the better that you're doing. You can see here there are a couple outliers up at the top that are in the red that can really be dragging down your score. As you can see, the volumes are pretty high patient-wise. And you can understand by taking a look at this that these are people that you want to concentrate on, especially if this is in the beginning of the year that you're doing this. So when it comes to MIPS analytics by insurance, what you have here is we have the ability to track it by insurance for you as well. So this is what I was talking about, being able to go back to these private payers and talk to them about how well you are doing with each one of these measures. And it also allows you, before you go do that, to take a look at it and decide where you want to make your impact and where you want to make your changes. Because if you're able to do that, you'll be able to show them really good numbers that can really help you out in a conversation that you might be having about where you are on their preferred lists and so forth. So you want to take a look at disease states as well. Inside here, what you're seeing is the difference between each of these patients and where they fit for this measure based upon their disease state. So you can see here, you have your patients that have Alzheimer's and their diabetes report. This is an area of concern because these 2 comorbidities are matched, and you want to make sure that you're doing a better job with these patients as they are a large chunk of your business, as well as they are doing poorly for this measure. And you could see for each one of these, you could really dig into where it goes and how it can help for each one of the disease states. So taking a look at the most advantageous for MIPS scoring improvement. So what you see here is a list of each one of your measures and where you stand. It's really important for you to take a look at a number of certain areas that can help you improve on your score. So if I were to take a look at this overall dashboard that you're seeing here, there would be certain things that stand out to me. So for instance, you want to take a look at the number of patients in the denominator. So you can see here for a measure like diabetes, this is actually a very low patient population compared to the rest of your groups. So for every single met or not met, you could drastically change your score for a measure like this compared to a measure like the preventative screening, knowing that if you did well with only another 10% of your business, your score is not doing much better. So that's taking a look at the number of individual patients. Then you want to actually take a look at the decile ranges. So as you can see here, a measure like 438, the statin therapy, it's going to take a whole lot of effort and a whole lot of work for you to get up into these other deciles to gain more points. So if this is halfway through the year, you're probably going to say, yeah, this is the best I can do with this measure and not move forward. But for a measure like, there's a couple of them on here, a measure like the preventative care screening for depression and follow-up, you can see that you can make systematic gains throughout the entire process to get a better score. So the deciles are a little closer together. Same thing with your diabetes, the deciles are a little closer together. So the better that you do, every single patient matters in your scoring. And then the other thing that you want to take a look at is the difficulty of closing gaps. So the important part for this is take a look at those measures that are once per performance period, because if they're once per performance period, what's nice about these measures is that you have the opportunity to catch up. So instead of it adding a patient onto the denominator, it will just override the numerator with the new answer. All right. So I only have a couple more slides to go. So if you have questions, please ask them away. Otherwise, we'll be able to get out of here in a good time too today. So MIPS Pro offers live dashboards and drill down capabilities. So here you're taking a look at that dashboard that I showed you a couple minutes ago. This is showing you what you're doing for your met and not met for each of the individual measures that you see here. Also can drill down further into your actual patients and take a look at each one of your patients and patient visits to take a look at all of your scoring, track as many measures as you'd like within our program, and give yourself the ability to maximize your score working with our top-notch customer service people and integration team. So feel free to reach out to me. You could reach us at contact@healthmonix.com or me directly at mlewis@healthmonix.com or that phone number, or go directly to my department. Give us an opportunity to show you how we can help you with your MIPS scoring, as well as any of the other programs that you're working on. If you're on this call and you are doing the PCF or APP programming or any of the other ones, then you will have the opportunity to work with us as well. We are working with all of those programs. So thank you very much. And I'm going to give it a minute to see if I get some questions in. Otherwise, I'm going to wish everybody a wonderful day. Have a good weekend, and good luck with the rest of the summer. So give me a couple seconds. I'll see what I have here. Lauren, so there's a question on here. Have the cost measures been posted at CMS for 2020 yet? Maybe you'd be able to give a little insight into what they did for 2020 for our listeners.
Sure. So for 2020, CMS has said that they are not going to utilize the scores as part of your final MIPS score. They're basically going to eliminate that component, and reweight the other components. They said that they felt like there wasn't enough data to give valid results based on the fact that it was, you know, the pandemic and the number of in particular, the inpatient measures the data was not sufficient to come up with valid benchmarking. So you will not get scored on it. The question at hand, though, is whether CMS will post that data, because we do want to see it. So we are advocating to get access to that data. So far, CMS has been quiet as to whether we will be able to see that. And we will certainly keep people posted about that.
Good. Thank you very much, Lauren.
Sure.
Another question: does MIPS Pro work with Epic systems? I can take that one. Yes, we work with Epic. We are a proud partner of Epic. We're in the app Orchard. We have a direct integration with them and bring data over for them for a number of clients already. So if you are utilizing the Epic app Orchard or the Epic program, we could work with you to help maximize your MIPS scoring moving forward. I didn't see many more questions that would be relevant to the whole group, so I'll give it another minute or two to see if any come in. But elsewise, we can end this nice and early and give everybody 15 minutes back. I have someone saying they have a question and they're typing it now, so we'll wait to see what we get.
Mike, I see a question about eligibility and, you know, about the fact that in 2020, perhaps somebody had low volume or no volume. My suggestion would be that you check the eligibility either on the CMS website, or there is a MIPS eligibility lookup tool on the HealthMonic site that maybe I can post here. I'm going to try. I don't want to give you a definitive answer because they do have 3 different lookup periods. You know, it's based on low volume threshold. Did you bill more than $90,000 to CMS during the period? Did you have at least 200 patients, and did you have at least 200 visits? And if you meet all of those during their eligibility period, then yes, you are eligible. If you don't meet at least one of those, then you can opt in if you choose, but you are not required to report. If you met none, then you can do voluntary reporting. And if you have more questions about that, you can reach out and we can help you look that up.
Perfect. Thank you, Lauren. We did have a question come in here. So is there a specific site that contains information regarding MIPS measures as far as what you went over with the melanoma reporting code with 88305? How are we supposed to know that you can only get credit if you read your own path? So right on our MIPS Pro website, you'll be able to do that. And actually, I'm going to take a second. I'll actually show you what that looks like within our system so that you can actually go right in here and see what the measures are. So give me 1 second while I pull that up for you. Yes, we work with providers to help them do exactly what you're asking for, be able to take a look within the program what it's like for each one of the measures. So hold on 1 sec while I bring up our website. All right, we can see our website here. So you will click right here under MIPS measures. And then within the program, you'll be able to click on the all quality measures. And if you wanted to take a look at the melanoma measure, you could type in melanoma. And melanoma reporting is 397. So you hit view under that. And then what you'll be able to see here is what's included in the denominator, including any of the instructions that they have in the denominator for how it works, the patient age range, as well as the diagnosis needed. We also show here that this also has an and patient needs an 88305 for each measure. Within our MIPS Pro platform, though, however, you can actually type in your codes into our system and it will tell you what measures you are eligible for. So we have that for every single measure in the system. All right. Well, thank you everybody for joining us today. As I said, please be in contact with me if you have any questions. We are here to help you get through this craziness that CMS is putting in front of us for the changes and so forth. And if you need me, you have my number, you have my information. Everybody have a wonderful week and enjoy the rest of your summer. Appreciate it.